All right, why don't we get started? Thank you all for joining us. I'm Dr. Jason Siefferman. I'm an interventional physiatrist, pain management doctor. I'm at Manhattan Pain Medicine. We've been treating EDS for several years. We sort of enjoy tackling the complexities and the associated conditions, and we've aligned ourselves with a lot of other providers who also treat these conditions. And we've recently come together and decided to do a series of webinars to share our approach. Because as you guys likely know from your lived experience, there's a variety of approaches to this, and everyone sort of has their own recipe. So we're here to share ours. Today, the webinar is about joints, how hypermobility specifically affects joints. As you know, on the EDS spectrum, there are different kinds of EDS. There are different effects of each different subtype of EDS. But one thing they generally all have in common is joint hypermobility. So today's topic is quite relevant. Our approach to EDS and hypermobility spectrum disorder starts with identifying the primary conditions. And often people come in with pain as a complaint or dysfunction of a part of their body as a complaint. But we have to figure out why that's actually happening, the chain of events that led to it happening, and the chain of events downstream from that happening. So there's often a lot of buildup or snowballing that happens because we don't see this when it's brand new. It's been going on for several years. And, secondary and tertiary conditions sort of build up as a result of it. So we're trying to identify which joints are really the primary joints where the hypermobility is being affected and start with that. And then identifying the secondary conditions. So often muscles are sore, they're tight, they're guarding, they're overused to compensate for the laxity in the joint. Sometimes there's a dystonia. We'll see this with craniocervical instability, with other joints that just, there's a muscle guarding that is so intense that the muscle really becomes dystonic, which means the central nervous system learns to involuntarily contract that muscle no matter what. Often we'll see complex regional pain syndrome in the setting of hypermobility. So if you look at shoulder subluxation can pull on the brachial plexus. That can cause complex regional pain syndrome or a brachial plexopathy. You'll see it around the hip, where laxity around the hip will cause guarding of the piriformis. The piriformis will put tension on the sciatic, piriformis syndrome, or the obturator internus will react to a loose hip and cause a pudendal neuralgia. We'll see temporomandibular joint dysfunction. We'll see thoracic outlet. We'll see POTS and other peripheral nerve entrapments. So sort of just identifying what the core issue is, which is often hypermobility of the joint, and then the secondary downstream issues. Of course, we want to review all of this with the patient, make sure we're on the same page. We want to establish priorities and their goals for treatment. And of course, function is a big part of this, but of course, looking at pain, looking at everything else that's going on. And we want to start down a path of treatment. And the path of treatment often includes medications. Medications are really just for comfort. They're not going to fix any of the core issues, but they're a means to an end. And if they can help you get through the treatment that you need to get through to get better, to fix the structural issues, that's the means that they are. We talk about physical modalities, including physical therapy and occupational therapy, and we have both a physical therapist and an occupational therapist with us today who will be sharing their approach to hypermobility. We talk about procedures, specifically regenerative medicine procedures, including prolotherapy, platelet-rich plasma, maybe bone marrow. Dr. Kane is with us today to talk about these approaches because at the core, we have to treat the laxity of the ligaments and the joint capsules that allow the joint to move more than it's supposed to. And then, of course, the psychology of pain, because again, often by the time patients get a diagnosis and they've developed all these secondary conditions, their life is affected, their relationships are affected, their vision of themselves and their plans for their future life is affected, and sometimes even their children are affected. I have plenty of adult patients who had children who had pain before they themselves got the diagnosis. So there's a lot to work through. And then, of course, it's an iterative process, right? There's no one size fits all. There's no rubber stamp prescription. We really have to look at each individual patient, figure out what's going on, how it's happening, what the chain of events is, get to the core of it, see if they respond to a therapy. If they don't, we change the therapy, move to something else, see if they respond to that, figure out what they do respond to. Once we've done that, then we can sort of copy and paste to other joints and go in the order of importance to get all of this sorted out. And this is never a one-person thing. It's always a team approach because, when a joint has been adapted to for so long and those adaptations become chronic, you have to have PT, you have to have some OT. It's a team approach to get all of this done. And with that, I've basically sort of gone over all of these already, but let me just number these out. The key concepts. There is laxity, loss of elasticity of connection of tissue in the ligaments in the joint capsule, and that's the primary pathology. It's intrinsic instability of the joint. Gravity is not our friend. Gravity and joint laxity lead to compensatory mechanical patterns, meaning you will adapt how you use your body because of the laxity. So if the shoulder is subluxed, the shoulder blade will protract forward because it's a more comfortable position. If the hip is anteriorly unstable, the sacroiliac joint will rotate, the pelvis will tilt to cover the hip better. And that, of course, will put more stress on the back. It's going to change how you use your hip muscles. There's a whole downstream effect from all this. Trained correction of anti-gravity muscles is essential. That's mostly physical therapy. Compensatory biomechanics are suboptimal at best and cause other problems. So like I was saying, with the shoulder protraction, with the pelvic rotation, those are compensatory. They cause other problems. And the treatment must address, first of all, the patient has to become aware of the instability and the compensatory patterns that they're using to take care of this instability. And this is what we call proprioception. So proprioception is the awareness of where the joint is in space. So being aware that the joint is unstable, that it is lax, that it is subluxed, because many patients with EDS are chronically subluxed, and that feels normal. So gaining an awareness of subluxation as the current state rather than proper positioning, learning what proper positioning is and how to feel the difference. Anti-gravity training, core muscle training. This is the key compensatory mechanism. Becoming aware of postural changes that gravity causes and strengthening the muscles that work against gravity to optimize alignment of the joints to minimize wear and tear on the joints. Absolutely essential. The intrinsic instability of ligaments must be addressed. Otherwise, the joints, you can strengthen the muscles around the joints all you want. But if the joint is unstable, gravity is still going to pull it into a suboptimal position. It's still going to wear at a suboptimal position. And when you're sleeping, when these muscles are not active, when something catches you off guard, that joint, it's loose. It's going to do things we don't want it to do, and it's going to hurt. So really addressing the intrinsic instability of the ligaments, and really regenerative medicine is our only trick for that, is an essential part. And then, of course, how we use our bodies, our own mechanical patterns. Part of this is the compensatory patterns that have been developed, but then we may also just have some biomechanical patterns that are suboptimal that can be optimized. And this is what physical therapy is for, to really assess that and optimize that. So again, to speak with everyone today, we have Pepie, our occupational therapist, Melanie, our physical therapist, Dr. Kane, physiatrist, and then we'll do some questions and answers at the end. All right, so I'm going to now hand it over to Pepie. I will pull her slides up. Bear with me for just a second.
Thank you for having me tonight. My name is Pepie Lapsatis. I'm an occupational therapist, certified hand therapist. I have about 18 years of experience, and I worked at multiple medical centers in New York City, and I've had my own practice for about 12 years now, called Hands Up Occupational Therapy. Next slide. So I know we already covered this. EDS is a group of genetic connective tissue disorders that are more common among women. And it has characteristic features including hypermobility, skin hyperextensibility, and it can impact all of your joints in your upper extremity and is commonly noted in the digits, thumb, elbow, wrist, and shoulder. So what we're going to cover are some of the musculoskeletal conditions that we are all familiar with, including subluxations, dislocations, pain, weakness, fatigue, and non-inflammatory joint pain. Next slide. So managing the symptoms. We use a multidisciplinary approach of an occupational therapist, physical therapist, psychologist, physician, acupuncturist, orthotist, and nutritionist. And our goals are to prevent symptoms, improve some function, as well as manage the symptoms. So what is occupational therapy? Occupational therapy is a branch of healthcare that helps individuals with physical and cognitive disabilities restore function and gain independence. Occupational therapists work in various different settings, including rehab facilities, hand therapy clinics, pediatric settings, cognitive therapy clinics, as well as vision therapy settings. So hand therapy is what we're going to focus on. Hand therapists treat patients with physical and neurological conditions of the upper extremity. Many hand therapists will go on to pursue higher level certification and become certified hand therapists, meaning that they're experts in the field of upper extremity treatments. The goal is to rehabilitate, maintain, and prevent further injury to enable patients to complete ADLs, activities of daily living, and instrumental activities of daily living, as well as leisure activities. So how can EDS patients benefit from OT? So when a patient comes into the clinic, we conduct an initial interview and we gather all the information, including the patient's age, their occupation, their hobbies, and their interests. We also get their medical history, their diagnoses, the medications that they're taking, and their comorbidities. We ask the patient what their current concerns are. Why are they coming to OT? Is it a new mother that is having difficulty feeding her baby? Is it a musician that's having difficulty playing an instrument? What their goals are. We want to be individualized and specific and rank their goals in order of priority. We also want to observe the patient as they come into the clinic, as they're putting on their coat, as they're managing their credit cards, as they're completing their intake forms. And we conduct standardized assessments, such as the dynamometer, which is photographed in the top photo, or goniometric measurements to measure the laxity in their joints. We then gather all that information collected, and we come up with an individualized treatment plan for each patient. So what are some of the most common conditions that we treat in OT? The center photograph is a typical presentation of a hand that we see that has hypermobility in the joints, including the thumb. So the thumb is a very unstable joint often, and it ends up presenting as a zigzag deformity with hyperextension, meaning that it's more flexible in the one joint, which leads to flexion, meaning that it's more bent in the top joint. So that is a common presentation in the thumb. In the fingers, you tend to present with more of a swan neck deformity, which, as you know, the finger has 3 joints. The middle joint hyperextends and the tip joint bends, and it kind of looks like a swan's neck that's hyperextended and flexed. So those are the common hand issues that we see. Next slide. And we also treat wrist hypermobility, elbow hypermobility, and shoulder hypermobility. So the elbow hyperextends often, and it looks similar to the photos in the slide over here. Next slide. So what is our goal? As we mentioned earlier, our goal is to manage the pain, strengthen patients, increase their endurance, educate the patient on activity modification, joint protection, complete ergonomic assessments, and prevent future injury. Next slide. And how do we do that? So in occupational therapy, we implement multiple modalities, such as ultrasound and TENS. In the first photograph, the therapist is doing ultrasound over the CMC joint, the basal joint of the thumb, which can often be hypermobile, causing a lot of inflammation. So we apply ultrasound to the area to help reduce the inflammation and decrease some of the pain and the symptoms. We also apply manual therapeutic techniques, including soft tissue mobilization, joint mobilization, transfriction massage. This is often done, again, to decrease some of the pain, stimulate some blood flow into the area to help with the healing process, and manage pain. Another specialty that we do, and I'm going to go into in further detail in the next slide, are orthotics, which could be either custom or prefabricated, as well as taping techniques. Next slide. So orthotics, which are also known as splints and braces. What is the purpose of orthotics? The purpose of a brace is to provide stability, support, manage pain, immobilize and rest a joint, and improve function. There are 5 main splints that we make in our clinic, which is the wrist cock-up, the thumb spica, the figure 8, the posterior elbow, and the ulnar gutter splint, and I will go through each of those. And we actually prefer custom orthotics because they are custom molded to fit each patient. They are molded the same day in the clinic using thermoplastic material. And we will usually decide on what kind of splint to make, whether it's a custom or prefabricated, based on the clinical presentation of the patient, their body part, their age, the purpose of the splint, as well as, unfortunately, insurance and finances. Custom splints tend to be more expensive, so we will take that into consideration when we are discussing the plan with the patient to come up with what is most appropriate for them. So digital orthotics, these are probably the most common splints. And as we mentioned earlier, one of the most common presentations is a swan neck deformity or a zigzag deformity in the thumb. So in the top photograph is a custom-made figure-8 splint that is helping a patient hold a pen and grasp so that they can write with greater ease. What this splint does is it keeps the tip of the thumb, the joint, in a 30 degrees flexed position, which is a more functional position, and prevents that joint from hyperextending to enable them to grasp a pen. This one was custom molded for the patient. In the lower photo, there is another a photo of the thumb. That is a figure-8 splint that is prefabricated. You can order it based on size, but that one does not provide the flexion that the top splint does to maintain the 30 degrees of flexion. However, it does prevent hyperextension of the joint. Those same splints come in multiple sizes, so they can be worn on all joints of the fingers. And then in the picture all the way on the right, that is a silver ring splint. Those are a little bit pricier as well. Those can be measured to order, and those enable you to keep your finger in that flexed posture, like we said, to prevent hyperextension and allow increased function of the hand. Next slide. So for the wrist orthotics, there are two most common wrist splints that we make in the clinic, and that includes the wrist cock-up splint, which is in the top photograph, which is custom molded, and the ulnar gutter splint. The wrist cock-up splint provides general stability in the wrist, and the ulnar gutter, it's custom fabricated and provides support ulnarly on the wrist. So depending on the location the patient is presenting with more instability and or pain, we will decide which splint is appropriate for the patient. The ulnar gutter splint, unfortunately, does not come as a prefab. However, the wrist cock-up does come as a prefab, and we have a photograph of that there. So depending on the patient, their insurance, and what would be easier for them, they can either get the custom one or the prefabricated one. Thumb splits. So there are two different types of thumb splits as well. There is a hand-based thumb spica splint in the top photograph, and then there is a forearm-based thumb spica. The hand-based does not include the wrist, and the forearm-based obviously includes the wrist. So determining which splint, again, we're going to assess the patient and determine which one is more appropriate for them. The hand-based one allows increased function because it allows the wrist to move. However, in cases when the patient is having a lot of pain and or instability in the wrist, we will often recommend the forearm-based splint. Sometimes we actually even make both splints for our patients because they can use the hand-based one during the daytime for work and functional tasks and wear the forearm-based splint at night while they are sleeping, so they can get relief and support at night. There is also a prefabricated version, which is a neoprene splint that we do recommend to patients. It's less rigid and provides a little bit more mobility in the area. So some patients do prefer that for work-related activities or increased function. And over here, this is a posterior elbow splint. So with a lot of patients, when they extend their elbows, unfortunately, the elbow will dislocate. So depending on the presentation and the acuity of the dislocation, we will determine with the physician how long the splint needs to be worn. And it could be worn anywhere from 3 days to 3 weeks to help decrease the dislocation, as well as worn for comfort, support, and stability at night when the patient is sleeping. So, the wearing of the splint is determined on a case-by-case basis, depending on the presentation the patient has. So another thing that we do at our clinic is taping. So kinesiology tape is a thin water-resistant tape that provides support, stability, and pain relief to joints and muscles. How does it work? It lifts the skin to create a space for improved lymphatic drainage and decreased inflammation. It provides support to the joints and muscles. It stimulates nerve receptors to reduce pain and improve body awareness, such as proprioception. What are the benefits of kinesio tape? It's easy to apply, it's non-invasive, it's cost-effective, it provides stability while allowing mobility, and it can be worn for several days. So the effects of taping. In a study conducted by Tudini et al., they actually evaluated the effects of taping on two different taping techniques on the shoulder. And ultimately, it didn't matter which technique you used. The conclusion was that K-tape is an inexpensive and relatively safe intervention that is easy to apply and can offer temporary improvements in pain and function for patients with EDS and shoulder pain. So in our clinic, there's various different types of tape. Comes in different colors. It comes in different, there's various different types of companies that create the tape. So we use it for various different patients and diagnoses. In the top photo, for patients that present with hypermobility in their digits, we do a figure 8 pattern, which is similar to the figure 8 splint over the joints to provide some increased support and stability. Now, similarly to the splint, it helps with the stability. However, unlike the splint, it does not cause any, it allows full function and movement. So it allows you to use your muscles and not cause any of the muscle wasting or atrophy. And in the joint, in the thumb joint, that's another, like we said, that's one of the most hypermobile joints. There are different taping techniques. The top one does not go down the forearm as much, and it provides more support at the basal joint, while the other one provides support dorsally and volarly around the thumb joint. These are other taping techniques that we use in the clinic as well. As you can see in most of them, there's a lot of thumb involvement, but there are also patients that have instability and or pain on the opposite side of their wrist. So that is another taping technique that we do in our clinic as well. So because it is occupational therapy, in addition to the splinting and the taping, strengthening is a big part of what we do. So, we do a lot of the traditional strengthening exercises of the hand, forearm, upper extremity. We provide stability to the joints to decrease pain. We complete proprioceptive exercises as well as weight-bearing exercises. And that bottom photo is a photo of my team with all of our fun exercise tools that we use in the clinic to do various strengthening type of exercises. So as OTs, our goal is always to improve function. So activity modification and joint protection are some key aspects of occupational therapy. And that is a temporary change to daily activities to help reduce pain and prevent injuries. So these are several adaptive devices that we will introduce to patients and discuss with patients because it might be helpful for them to get through their daily tasks. The top one is a button hook. The middle one is a lever arm to help open doors. And in the bottom photo, it's a photo that I actually found, and it's very similar to the figure 8 splint that we made in the clinic with a built-up pen to allow the patient to improve function. Okay. And on the photo to the left is something that we did in our clinic. This patient was a drummer who had a lot of hypermobility in her left thumb. So we fabricated her a custom thumb spica splint to provide stability in her joint, as well as applied Dysum over her drumsticks to increase her grip so that she required less force to hold the drumsticks to improve her function while she played. Ergonomics is another key thing. So as OTs, we do a lot of ergonomic evaluations. Sometimes we will visit the patient's offices. Other times, we just have the patients send us photos of their workstations. And what we will do is we will assess and provide feedback. We'll give them recommendations on various chairs, an ergonomic mouse, gel supports, and positions that they can be in to optimize their position as well as function while using their workstation. So the final tips and takeaways. Occupational therapy is critical to assisting patients with EDS and HSD. The goal is to maintain and improve function. Treatment is individualized and specific to each patient, and a multidisciplinary approach is used. Patient education is key. Activity modification and protection techniques are a big part of what we do. And unique treatment techniques such as orthotics, splinting, and taping are a big part of our practice. So thank you everyone tonight for listening in. If you think you could benefit from OT, please feel free to reach out to our clinic or to your physician because if it's appropriate for you, then you could get a referral to occupational therapy. Thank you again for tonight.
Thank you, Pepie. Next, we will hear from Melanie, who unfortunately couldn't join us last minute, and she submitted a video.
The owner of Inspira Physical Therapy. Hello, everyone. My name is Dr. Melanie Carminati, and I am a doctor of physical therapy, and I'm the owner of Inspira Physical Therapy and Pilates. I will be presenting about physical therapy for people with HEDS and HSD, and getting into details about orthopedic and musculoskeletal considerations. The agenda, introduction, we'll talk about physical therapy for people with HSD and HEDS, pain science, joint stabilization. I'll talk about how we use Pilates. There will be a video demo, proprioceptive and strength and endurance training, task-specific training. There will be a video demo for that as well. I'll mention some compensatory patterns to watch for, as well as what the goals of physical therapy are for people who have HEDS and or HSD. And long term, we want to be promoting that independence in management and care with check-ins as needed. So scope of this presentation, this is introductory in terms of what we'll be covering. Obviously, we can go into much more minutia than what we're going to cover today, but I'm going to do my best to hit all of the important points when it comes to physical therapy. Other comorbidities such as POTS and dysautonomia, MCAS as well, were covered in the introductory webinar, our first webinar for the New York Hypermobility Collective, so please reference that and watch that. I also spoke more about manual therapy and the research behind that for pain science in that same introductory webinar, so please watch that. If you are interested in pelvic dysfunction, pelvic floor dysfunction, and pelvic floor PT, that will be covered in an upcoming webinar, so stay tuned. I want to just put this out there so everyone knows how we treat and go into our plan of care for people who have EDS and HSD at Inspira. We have a 16-week program. Not everyone goes through the full 16 weeks. There's 4 phases of care. Sometimes people start in the second phase, sometimes the third phase. It's very variable based on how the person presents, but you'll see that we start with a lot of manual therapy, including craniosacral therapy and vagus nerve manual therapy, which is tremendously beneficial, especially if pain is the main complaint and the main thing that that person wants to work on. We go through lymphatic drainage, visceral manipulation, other manual therapy that could be orthopedic or pelvic floor. Radio frequency is referring to the wind back to car. Kinesiotaping we use a lot. And then the neuromuscular re-ed and therapeutic exercise. I'll be speaking more about the radio frequency, kinesiotaping, and neuromuscular and thorax portion of this multi-system approach, but the website's down at the bottom for you to reference if you want to look more and read this further. So physical therapy for people with HEDS and HSD. Individuals with HEDS and HSD have very unique presentations. As Dr. Siefferman showed in our first webinar, that spider map can show how someone might have the main complaint of pain versus another's person might have a main complaint of fatigue. So it's really variable, and because of that, it really requires a thorough and comprehensive evaluation to determine the functional level and where to initiate care. Collaboration with other providers is crucial, hence why we have formed the New York Hypermobility Collective. And the focus of physical therapy itself for orthopedic and musculoskeletal impairments should focus on pain reduction. That could be through soft tissue, manual therapy, central nervous system, peripheral nervous system, manual therapy, increasing joint stability, improving proprioception, increasing strength and endurance, and then taking all of those gains and translating it to functional movements for increased participation in activities of daily living. As mentioned in the beginning, long-term goal being to self-manage with check-ins for specialized care as needed. So pain science. This is one of my favorite quotes from Lorimer Moseley from Explain Pain. And this little excerpt explains how pain can be turned on and turned up by anything at all that provides the brain with credible evidence that the body is in danger and needs protecting. It goes into more details about inflammatory mechanisms, etc., and then remembering that it is not a pain message that's being modified, but a danger message. This is the dark side of neuroplasticity, and it's one of the significant reasons that recovery from persistent pain is seldom a quick fix, but requires a journey of patience, persistence, and good coaching. So I encourage anyone listening who is a person who has HSD or HEDS or other forms of EDS to find that therapist who is with you on that journey and understands the pain science and is encouraging and is going to help you stay persistent and diligent in your therapeutic exercise program. Key pain science points. How you think about your pain can change the way it feels. Understanding pain is important because it changes the way you respond to pain, and retraining the pain system may mean testing yourself physically, moving more than you normally would, and being honest about your current attitude and beliefs. In our first introductory webinar, Dr. Barbieri covered this in depth, so I again encourage you to look at that. So incorporation of osteopathic techniques, we use craniosacral vagus nerve manual therapy, visceral manipulation to help address that pain and help regulate the central nervous system. Then, once we've addressed the pain, if pain is the main complaint, we get to joint stabilization. So this goes into the orthopedic musculoskeletal side of things. And I am going to be referencing this article from Susan Chalela and Leslie Russick, where they really beautifully explain hypermobility and the components that you need to understand for proper physical therapy care. Joint stability itself is provided by three components: passive structures, such as ligaments, muscles acting on the joints, and then the nervous system providing feedback and motor control. And although hypermobility occurs when ligaments relax, it's the instability that occurs when muscles and the nervous system are not able to sense and control the joint motion. We know this because of the spectrum of presentations of people with HSD and HEDS. You could have someone with low muscle tone who has the ligamentous laxity and the joint instability because they have low muscle tone and their nervous system hasn't been trained or been given that chance to learn how to function in a congruent joint position. Or you could have a hypermobile professional dancer, say for example, who is certainly hypermobile, has a ligamentous laxity, but has muscle mass and tone, as well as nervous system control of the joint motion. And they are less symptomatic, experience less pain. So everyone's presentation is different. Everyone could have different comorbidities that make progress challenging. I'm just merely mentioning these two examples just to highlight how you can have ligamentous laxity, but not necessarily have the joint stability. But joint stability is one of the things that we really want to strive for. How to improve joint stability. First, we need to make sure that the joint is congruent and make sure that there is no subluxation or dislocation that's present. Obviously, achieving this is going to be different for each person, because if someone has lived with their shoulders subluxed or ribs subluxed for a long time, promoting change that is going to last will likely require different modalities, other providers, which I know that Dr. Kane and Dr. Siefferman will speak about. Prolotherapy is one of those modalities. Utilizing external supports and feedback to increase proprioception, which helps to then facilitate increased muscle activation. External supports could be something like the body braid, could be kinesio tape, could be bracing from an occupational therapist, could be props, bands, radio frequency. After all of that, we need to optimize posture. I educate patients about stacking and how to stack the head over the shoulders, shoulders over the hips, torso over the pelvis, pelvis over the ankles, and really just finding that ideal posture, that optimal posture, because when we are stacked, ideally, the muscles will function as we want them to, and they will function efficiently. After we have learned that posture, then we move into the safe range of motion, which takes time and takes many different types of verbal cues, postural cueing, tactile cues, imagery, you name it, which I will get into in a future slide. And then another important thing is to help educate our patients to identify the sensations of safe muscle activation, as well as safe range of motion, versus compensatory movement patterns that are not ideal for muscle activation. Joint stability continued. So what we do from a motor control standpoint, so motor control, motor science is something that we study as physical therapists. And when we are trying to acquire a movement, we will work first in closed chain, because this is the most ideal and gives the most proprioceptive feedback. And then we'll transition to, we use this in Pilates. I know this is not a commonly used term, but pseudo closed chain. I'll show you it in one of the videos coming up, and then progress to open chain. So open chain will be the most challenging for someone who is hypermobile, versus closed chain will be the easiest and the most ideal place to start when you are re-educating a movement pattern and when you're re-educating someone in understanding joint stability and joint congruency. So some of the verbal, visual, imagery cues that we utilize could be joint approximation. I use Franklin method cues. One cue for knee extension I use is to think of straightening your knees only 95% of the way. I emphasize bony cues a lot. Again, that goes back to the stacking, as well as arthrokinematic motions. For example, dorsiflexion, I will be palpating and touching at someone's talus, educating them about the talocrural joint and how that's where I want them to be aware of motion happening from for dorsiflexion, instead of excessive Achilles tendon lengthening and feeling like really the back calcaneus is reaching and doing the motion. I mentioned the stacking already. One other cue that is helpful is to think of the kneecaps sliding up towards the hips when you're trying to facilitate knee extension. I find this is very helpful. Pilates. So at Inspira, we do use Pilates quite a bit. Pilates is a mind-body movement method, and it is extremely ideal because breath is one of the primary principles of Pilates, and it's one of the main things that we're cueing. And what happens with that breath cueing is it helps to ground a person in the present moment, and it helps to increase that body awareness, which then leads to increased proprioception, and then leads to decreased chance of injury. When someone is in their body and they're aware of the movement, this is ideal for rehabilitation. Okay, as a disclaimer, some of these exercises I'm about to show, it's not individualized medical advice. I'm just showing them so you have a reference of some things I might do. If you're looking for individualized physical therapy advice, please see a. Okay, so here we are. This is a clip from our Pilates for Hypermobility workshop, which happens every May at Inspira. So in this video, we're doing footwork on the reformer. I have her using 2 reds and a blue. Anyone who's watching this who's a physical therapist or Pilates practitioner or a person who uses Pilates, this is a balanced body reformer, studio reformer. So I'm having her, let's see what we're saying.
I'm sure there was think of the kneecaps sliding up to front of the thighs.
Yep.
Yeah, good. Okay, so just like a minor correction for her with the knee extension and then cueing for the patellas, the kneecaps to be sliding up the front of the thighs to get more quad activation. And so what else can we see here? So I'd like for you to put a little bit more weight through your big toes. That's it. Nice. Good. Okay, and so she's doing it very well right now, but some of the cues that you could be doing in terms of Franklin method cueing could be the spiraling of the femurs externally with the internal spiral in the shin and then another external spiral through that dorsum of the foot. That is really helpful, but she's doing it really well right now.
Okay, so that's just an example of footwork, parallel footwork, some cues that we might do, and as well as with this particular person, this particular patient, they are a mover, so they are very responsive to different verbal cues and imagery cues. So that's just one example. I'll show another. Okay. So next, proprioception and strength and endurance training. So for proprioceptive training, for different manual therapy techniques that you could be using as a physical therapist, this could be PNF patterns, rhythmic stabilization, muscle facilitation, when back to car therapy. We use different resistance, as you see in the photo. One of our Pilates teachers there is using a TheraBand to help facilitate more connection to the back rib cage space. Pilates springs are amazing, weight-bearing exercises. You see all that stuff listed there. And then strength training and exercise principles. I did touch on this in our first presentation as well, but I want to just say it again because it's important that my recommendation, if you're starting with exercise, is to start with exercises for time or duration. For example, instead of giving 2 sets of 10, have someone do an exercise for 30 seconds. This is very much Muldowney method based. That is one of the aspects of Muldowney method that I still pull from a lot, is doing exercise for time. This allows them to focus on quality movement and body awareness. Eventually, once they have progressed to a certain point of time, then we would move to reps and sets. I always recommend using moderate resistance versus light and focusing first on core strength and hip stability before extremities. It's good to focus on the stabilizers around the joints before the global mover muscles. Transition to functional movement. So again, these are exercises that are not individualized. So if you're looking for something specific, please see a physical therapist. Give me 1 second to get
In the forearm, I automatically feel that magnet area activate, getting some serratus and some lat involvement. And so this is where I would start just finding this, sustaining this for duration to build up some endurance here. So what are some other things that might come up? Just being in that position is the wrist. So many people who are hypermobile and or have EDS have challenges with their wrists. They might be wearing braces or splints. So if being in this position is challenging, I know you ladies on the screen probably know a lot of these modifications, but I'm just going to grab a weight. And I think at the studio that you both are at, you have that hand grippy thingy. But if you don't have that hand grippy thing, this is a 12-pound weight. They could be holding like this so that their knuckles and their hands aren't on the table itself. That just gets them to be in a nice neutral wrist position, and then they can do the same exact thing, that external spiral in the humerus, internal in the forearm, and then getting that magnet connection here. So this is where I would start. After that, I would play around with lower extremity isolation. Again, just doing some endurance first. After this, I would try, I'm just going to get rid of the weights because I don't need it. After this, I would try to do some gentle hand slides, getting them to be able
Just gonna skip ahead so we can get to a
to
pseudo
do if the thoracic
really
spine
strain.
is subtle scapular lifts. Now, while they're doing this, I encourage you to use hand slides.
Okay, so you saw there with me with the bar sprung from below on the trapeze.
It's a challenge also for people.
Let me just get to a second. There we go. Okay, so this is scapular work, trapeze. Right, compensatory patterns of movement, physiological movements. For hip abduction, we're watching for excessive TFL activation, where we want to be really seeing more gluteus medius, diaphragm excursion. Diaphragm physiology is a challenge for people who have EDS and HSD. And so watching for other compensatory muscles such as the neck and posterior postural muscles, upper extremity flexion abduction, upper trapezius and neck engagement again, and then hip extension. Commonly we'll see low back musculature and calf over engagement instead of the true hip extensors, glute max, and proximal hamstring working. So goals of physical therapy. After short-term goals are met, then we want to get to the long-term goals of independence and managing symptoms. The goal of a physical therapist or for the physical therapist is to provide the patient with as many tools for self-management and empowerment for independence in their own care. When you're working with the physical therapist, you want to make sure that they're experienced in assessing movement patterns of people with HEDS and HSD. This is really crucial. And then again, it takes a team. So remember that if you have HSD and or HEDS, you really need to find your team of providers. And I know that takes time. We all know it takes time to just get the diagnosis in the first place or just find that information. So having a physiatrist on your team, rheumatologist, and different providers is going to help facilitate that physical therapy progress as well. These are my references. Here's my contact information.
Hello, I'm Dr. Kane. How is everyone doing tonight? I'm a physician at Manhattan Pain Medicine, focusing on interventional regenerative approaches, diagnostics for pain management, as well as with the focus especially on hypermobility syndromes. I also do some consulting for a group called Research to the People, which we'll talk about sort of at the end. With some interesting projects that are going on there. What are the considerations in hypermobility that we look for when a patient comes in? It really starts with the history and physical. I know that Dr. Siefferman talked about this a little bit, but we have to identify what are the pain generators, what's really causing them the pain. And then once we've identified where their pain is on physical exam and from a thorough history, we have to see if there's any what I call a priori conditions. That could be conditions that are systemic inflammatory conditions, such as a rheumatologic condition that may be affecting and causing excess inflammation, or something like spine pain, where the patient has a herniated disc in their back or their neck that is causing the nerve to be inflamed and the joints in the arms or legs to be even more sensitized. And so these are things that we have to identify so that we have the best treatment plan for the patient, because when there's more inflammation and nerve issues, the actual treatments, we need to make sure that those are all being treated and under control. Again, there's what we call, on a similar note, primary and secondary types of injuries that we see. And sometimes the patient will be coming in and with their chief complaint being a secondary injury. Let's say they have a lot of pain in the side of their hip, but the primary injury is actually in the hip joint. So those are two different areas where we need to look at and treat, and we'll treat both of them. But if we don't identify the primary area, such as a labral tear in the hip versus just treating the tendon insertions at the lateral aspect of the hip, where they have more pain and inflammation, then we're not going to get a complete treatment out of that. And of course, with this, we have to work with the physical therapists and occupational therapists in order to strengthen through the joints and stabilize and correct movement patterns so that the injuries are injuries are stronger, and that the patients don't re-injure themselves by having movement patterns that are decompensated. Then we have a discussion about psychosocial factors that can be nutrition based, where some patients need counseling in nutrition, and we can refer out for that, or just have discussions on what types of nutrition they need to incorporate in their diets in order to heal better. Exercise, general exercise, being cardiovascular, being strength training, and making sure that there is a plan for that, and that it's pain-free and progressive exercise. Oftentimes that'll be guided by physical therapy and occupational therapy, but of course there's other forms of exercise that such as cardiovascular that can be incorporated that increase the overall healing potential in the body. Some psychological factors are the beliefs and goals of the patient. Some patients are athletes and they want to get back to running a marathon. Others just want to be pain-free, and that's where they want to be. And so tailoring each treatment to what that means for them is what we need to do. And then in the beliefs areas, managing the expectations on how the particular injuries will get better over the course of the treatment, and what the lifetime needs are, especially in patients with hypermobility considerations, where there may be defects in collagen production and laxity of multiple joints. And it's an ongoing process. It becomes an ongoing process of treatment for different areas. And then, of course, work-life factors. We treat all people with all different types of jobs, construction workers, again, athletes, just regular office workers. Each of those jobs have unique challenges for stress and stressing out the body, and repetitive type injuries. And then there's caregiver roles that I like to talk about a lot, and that can mean for a child, for pets, which both have involve a lot of bending and picking up things, which for patients with hypermobility, that can strain a lot of joints in the back, the hips, the knees, neck, and shoulders. So talking about those and making sure that our patients are incorporating what they've learned in physical therapy, and identifying areas where they do they may have difficulties and cause repetitive injuries. Next slide. Okay, so here's our regenerative toolbox. It really consists of three main types of injectates, and then there's different types of needling procedures that we do with them. So prolotherapy is really our workhorse of the injectates, and that's simply dextrose, which is sugar, and anesthetic, such as lidocaine, used to be injected in a joint, tendon, or ligament. And what this solution does is it creates what's called a controlled osmotic induced wound, where the there's actually the injectate will osmotically kill a few cells where we inject it, and that helps release local cytokines and factors inside the cell in order to trick the body into thinking that there's a wound in that area, and that causes inflammation, which we'll talk about in the next slide. That brings the inflammation stimulates local factors such as resident stem cells that are within the tissue, as well as systemic factors that bring in nutrients as well as circulating stem cells into the area where we've created this pseudo wound. One of the big draws of prolotherapy for the hypermobility patient population is that it tends to have the highest rate and ability to tighten ligaments and tendons. And in patients, especially with subluxations and dislocations, it becomes a very important tool in order to help during the process of healing. And as Melanie was mentioning, with physical therapy, they're really working on getting the muscles to work better through the joints. And when we work with PT and OT, and we can strengthen and tighten the ligaments and tendons, we can get that global picture around a joint and to stabilize it and make it pain-free. And then when we do, when there is tightening of the ligaments, that helps increase the proprioception within that joint. So it helps the patient move better, know where, and be able to do better physical and occupational therapy, as well as prevent injuries due to the ability of moving better. One of the interesting newer uses of prolotherapy is what's called neuroprolotherapy, where we'll actually go in and put the dextrose solution in a lower concentration around nerves, such as the median nerve. Lots of patients with carpal tunnel syndrome benefit from this, and there are actually some of the more robust studies on prolotherapy show that a 10% dextrose solution is as good, if not better, or if not superior to the standard of care, which is a cortisone injection for treating carpal tunnel. And a lot of our patients are steroid intolerant, and that makes a favorable injection solution for them. So, and sort of going back to Pepie, with hands, if we're doing the carpal tunnel injections and we're treating that nerve, when the nerve is healthier, it's able to stimulate, it's able to fire better, which means that it can recruit the muscles in the hand better, as well as when the nerve is healthier from the injection, it allows what's called neurotrophic factors to travel down the nerve and into the muscles that it's innervating. And those neurotrophic factors will help the muscles actually grow when they're being trained with therapy. So that's sort of a newer but better documented and researched area of prolotherapy that I really enjoy doing in a few different areas in the body. Next, we have platelet-rich plasma. This is where we take out blood from the patient, their own blood, and spin it down in a centrifuge in order to get a solution that's rich in cytokines and platelets, and we inject that back into the joint, tendon, or ligament. And again, that stimulates a wound healing response in a bit of a different way. It's a bit more inflammatory, but it's the good inflammation where the body sees that there's a small wound in this area, and it responds with the local and systemic response in order to lay down new collagen as well as proliferate the fibroblasts and other local connective tissues. The picture we have here on the right side is the tubes that we use to concentrate the plasma, and the nice amber colored solution there is what we get after we've spun it down in the centrifuge, and that's what we inject into the area, the painful area. And like platelet-rich plasma, bone marrow aspirate takes autologous bone marrow. We get that from the iliac crest, and we spin it down in a centrifuge, and again get a nice amber-colored injectate, and place that under ultrasound guidance into the area of damaged tissue that signals a wound healing response. From prolotherapy down to bone marrow aspirate, prolotherapy is the least inflammatory, and bone marrow aspirate tends to be the most inflammatory, and it does contain a high concentration of the mesenchymal stem cells. So oftentimes we'll use this more so when we have something like a rotator cuff tear or a big labral tear in order to get that a quite large inflammatory response, and that will heal a larger defect. Whereas with prolotherapy, when we do the injections, we oftentimes will pepper the solution around ligament, tendon, or joint capsule in order to get many different small areas, and that helps in hypermobile patients, because there's often a large amount of micro trauma in the joint capsules that we need to address in order to tighten those in a global sense around the joint. And we'll see a little picture of that later about how we kind of do that. We can go to the next slide. So this is what happens in the regenerative timeline. So the first few days, first week or so, we call that the inflammatory phase, and that's where we have the good inflammation, and that's what the body thinks is a new wound. And so there's cytokines that are released in all of these techniques, where they're both pro-inflammatory and anti-inflammatory. So we will get patients that tell us that the next day they feel amazing, and they're not healed yet, but because there's some anti-inflammatory properties, they'll really feel good after even a single injection. More often than not, though, there will be in the inflammatory phase, there'll be some soreness in that area for a few days, and it's really manageable with ice and Tylenol. We make sure that patients don't take anything like ibuprofen, because that is an or steroids, because those are anti-inflammatory, and we want this inflammation there in order to draw blood into that area with the circulating wound healing cells. So that's things like PGF, platelet-derived growth factor, macrophages, phagocytes. The next phase is the proliferation phase, and that's when we really see things like angiogenesis, where new blood vessels are being formed in that area in order to feed the new tissue growth. So you need blood to heal, and angiogenesis is when new small capillaries are formed in that area in order to feed the new tissue and really build that up. And resident fibroblasts are also very active during this phase. They one of the big things they do is secrete type 3 collagen, and that really helps strengthen especially ligaments. And that this is one of the phases when there's more connective tissue that's being put down, where patients really do start to feel better and get stronger. This is when we'll start the patient on therapy as well. I like to generally wait about a week and until these do start therapy. Some patients, maybe 2 weeks if they're a little bit more sensitive and inflamed, but we don't have any patients, we don't put them in braces or boots or restrict any activities during any of these phases. And we encourage pain-free progressive range of motion, as well as strengthening and guided under a therapist. And then what we have is the remodeling phase. Also, some people call it the maturation phase, where the tissues such as collagen are remodeled and what's called cross-linked, and that increases the strength of that tissue. And really, we see this 6 months, and it's still active up to a year or so. And some patients will really, at the 6-month mark, start to really feel better, even if they didn't necessarily at the 4 to 6 week mark. Most often, patients will start to feel better at least at the 4 to 6 week mark. But I've been doing this for 5 or 6 years now, and I've seen a very wide range of healing responses. And some of that has to do with the patient's intrinsic generalized healing. Other aspects of it are can be biopsychosocial, such as, let's say, a construction worker that's using a jackhammer within a week of the injection, which I've had plenty of before. It's not an uncommon scenario where they have to go back to work and use a jackhammer or shovel snow, or manual labor, and it's in theory not ideal, but these are the biopsychosocial factors that our patients, that's the reality of it. And sometimes it will take multiple injections then, but they will really start to get an effect after maybe 2 or 3, and then start feeling much better after more at the 3 to 6 month mark, because they are continuously stressing and straining out those areas. But oh, there's the rest of my, yeah, okay. And so that's all right. Next, and there's 2 bullet points on this one. Yeah. Okay. So we talked a little bit about this, but there's really 2 approaches in the interventional aspects. One is what I call the classical and initial types of regenerative treatments, where we're really targeting a global area. So I'll talk about the knee here, and what that means is that we'll do the injection inside the joint and put most of it just inside the joint, and that will cover a large area inside and inside it, yeah, inside the joint, and get all of the internal aspect of the joint capsule, as well as any internal ligaments that are in that area, such as in the knee, there's that ACL piece and PCL. And this gives us a chance to see what the patient's response to treatment is. Some patients are very sensitive and will have a larger inflammatory response. Some patients really don't feel much of an inflammatory response, but they still get a good clinical benefit from it. And so that can guide us into how frequent we want to do injections or maybe need to do injections. Oftentimes, prolotherapy will do an injection every other week for 2 to 4 sessions, and kind of piggybacking on that inflammatory response. But if the patient is still having a lot of inflammation, then we can wait on that for a little bit longer. I didn't mention, maybe I didn't mention this before, but this is an picture under ultrasound of the medial aspect of the knee and the ligaments, meniscus, and joint. And we do all of our procedures under ultrasound in order to correctly identify where the needle is being placed. And I'm additionally board certified in diagnostic musculoskeletal ultrasound. So I'll often do a complete joint exam, and for the more advanced regenerative type treatments, I'll identify where there might be some micro tears, tendinopathy, ligaments. It's called encephalopathy, and and structure the treatment in a more focused way, in order to be more thorough. Here, the arrow is pointed towards the deep aspect of the MCL, and we can see that it's a darker tissue than the other. Let's see. Then the part of the MCL that's on the right hand side of the screen, where it's lighter, and you can see the fibers a little bit on that right hand side. But where the arrow is pointed, it's what's called a fusiform shape. It kind of looks like a football, and it's dark, which means there's swelling and edema in that ligament, and that would be a good target for that would be a good target for focused treatment with a regenerative approach. Next slide. Okay, so I get this question a lot. How long do the regenerative treatments last? And that really depends on the extent of injury, severity of disease, comorbidities. We often have repeat microtraumas from work or just home activities, new injuries. I do a lot of education on how when there is an injury, especially with my laxity of joints in hypermobility, that you might start feeling better and really feel better and forget that you had an injury there. And I have far too many patients who will go and start doing things like bench press again because they feel great. And I really do a lot of education to make sure that they're not they're remembering that they have an injury, and that tissue has some compromise to it. And even if they're feeling great, that they're at higher risk for re-injuring. And then, of course, adherence to physical therapy, because that's going to keep them in a maintenance phase of staying strong through those joints and not subluxing and not re-injuring. Okay, so to kind of wrap things up, some up and coming research. This last year, we published a case study on shoulder prolotherapy in 3 patients, and we're hoping to do more both case series and getting some actual studies within our clinic that we can enroll patients in. And because the overall the research with hypermobility and specifically is needs to be done. It's not there's no robust compendium of research for hypermobility syndromes, and it's a area that is important and has a lot of potential to see good regenerative treatment research. One next this last year, with research to the people the group that I consult with, we had a EDS patient with the TNX B subtype get what's called a full telomere to telomere genomic sequencing, and that is a unique genomic sequencing process that actually gets some of the aspects that have not been able to be studied prior sequenced prior for Ehlers-Danlos patients, because other techniques aren't able to get in what's called the histone regions and look at those genes. And another project that we're working on is looking at fibroblast response to prolotherapy in microgravity. It's basic benchwork research, but it's kind of a fun project. Trying to send up some fibroblast cells and look at